I'm Lee Ellis. I am here at the 17th Annual Symposium on Anti-Angiogenesis and Immune Therapies for Cancer. We are here with George Sledge and Robert Kerbel, both co-chairs of the meeting, along with myself and several others who couldn't be here for this expert perspectives. So, friends and colleagues, we just finished our new meeting where we expanded it to include immune therapy in addition to anti-angiogenic therapy. Bob, what did you find were the highlights of the meeting, especially going back to the first day and proceeding from basic science, translational science, into the clinical outcomes on day 3?
Right. Well, I think that some of the interesting things that emerged from the first day of the meeting, which was really more basic science oriented, are some of the reasons, at least in theory, why combining an anti-angiogenic drug such as bevacizumab or some of the TKIs with an immunotherapy, for example, an immune checkpoint control antibody, may work together in a way that provides greater clinical benefit without a commensurate increase in toxicity. And so I thought on the second day, especially when there are a number of clinical presentations where a number of trials, small trials or pilot studies were discussed, in fact, combining those two therapeutic strategies, the signals, the preliminary signals, I think in most cases look very interesting and very promising. That will be something I think will be quite exciting next year to see, in a more advanced stage.
So to get more specific in that regard, obviously in targeting angiogenesis, we have a number of TKIs and a number of antibodies and traps and so forth. When you look to the future, do you think we'll be combining immune therapies or checkpoint inhibitors with TKIs, or do you think we'll be combining them with antibodies? Is there a preference for one or the other?
I would say, based on a few things that were discussed at this meeting, probably the more promising thing is antibody plus antibody. For example, there was a discussion today at the meeting where a anti-angiogenic tyrosine kinase inhibitor was combined with nivolumab, I guess, and although there was additive efficacy, there was apparently synergistic toxicity. And I would expect that that would not be the case, or at least not to the same extent when, say, one combines an antibody such as ramucirumab or bevacizumab with an antibody that's an immune checkpoint control.
George, you've witnessed the field of angiogenesis from the beginning in the clinic as well as from the lab. In combining the two, do you think antibodies would do better combined with the checkpoint inhibitors? Do you think kinase inhibitors would do better, or what are your concerns?
I think it's too early to say yet. The ideal thing about the antibodies, of course, is their great degree of specificity. So if one is looking for a specific on-target effect, then the antibody is certainly likely to be the better way to go. Particularly in the combinations with immuno-oncology, we certainly have a large amount of preclinical evidence and some clinical evidence that anti-VEGF therapies modulate the immune system, that they affect dendritic cells, they affect T-cell trafficking. So combinations of anti-VEGF therapy with immuno-oncology drugs certainly are rational from a biologic standpoint. It's a bit too early yet to say whether or not these are in fact going to work. I don't think we know yet. But it's certainly an area that's exciting and certainly an area that may turn out to be important going forward.
Were there any disease sites where you were pleasantly surprised by what you saw, either with single-agent immune therapy, single-agent anti-angiogenic therapy, or both? Did any, we're all in the field, we all see the stuff, we go to ASCO, we go to AACR, etc. Was there anything that you saw that said, wow, that was more than I had expected to see?
I guess I would say more of a general sense. The general sense that one gets looking at immuno-oncology is that it is targeting a very different population of patients than our precision medicines that have been developed over the last 10 to 15 years. If we look at how these things work, the immuno-oncology drugs, the checkpoint inhibitors targeting CTLA-4, PD-1, PD-L1, all of these agents appear to work better in the more highly mutagenized tumors. In contrast, one would say the targeted therapies, certainly the signal wonderful responses in targeted therapies have tended to be in cancers that are less heavily mutagenized, where a single dominant driver mutation is important for the cancer. So if one looks at the now classic Broad Institute mutations per megabase across tumors, what we're seeing is that on the far right end of that curve, the heavily mutagenized cancers such as melanoma, non-small cell lung cancer, bladder carcinoma, those appear to be so far the big wins for immuno-oncology. The less heavily mutagenized cancers on the other end of the spectrum are more the precision medicine, classic targeted therapy affecting a kinase type drug. The interesting question is going to be, are they going to meet in the middle? Are the combinations of these two going to work across a broad population, or are they going to work in very selected populations? And part of what we have yet to work out is where they meet in the middle.
I was surprised this morning at Mike Adkins' presentation when I saw immune therapy for renal cell carcinoma, where we've always thought of that as an immune-sensitive disease, and based probably on Steve Rosenberg's work at the NCI and IL-2, et cetera. And when I saw the response rates were probably about 20% with immune therapy, whereas with the standard VEGF inhibitors, it's about 40% as single agent. Maybe in some of the better trials. So, George, as head of medical oncology at Stanford, I'm sure your staff is initiating immune therapy, not only trials, but also practice for patients with melanoma. How are they being educated to use immune response criteria, see a patient whose tumor may initially grow? You have to talk to the patient about that and keep them patient to see if at the next imaging study they may actually have a response. How is your staff managing this issue?
Well, from a clinical trial standpoint, it's reasonably straightforward. In essence, one is basically saying, give it a bit more time before throwing in the towel. And that, in essence, is what immune response criteria means. We'll watch it a little bit longer than we would under normal criteria. I would say the big change, certainly for my faculty, has been that one has to be much more concerned about and apply much more interest in the management of the toxicity. These are not toxicities that medical oncologists in general are used to dealing with. I mean, we medical oncologists for decades have thought about toxicities in terms of things such as chemotherapy toxicities that are largely due to the effects on rapidly proliferating cells. Kinase-based toxicities added something a little bit different, primarily in terms of gut and skin toxicities. But now, immuno-oncology toxicities, we're having to deal more with things such as pneumonitis. We have to worry about hepatitis with several of these drugs and combinations of these drugs. And in particular, now when we combine kinase inhibitors with immuno-oncology drugs, we can expect to see a much larger spectrum of toxicities. And what's more, perhaps toxicities that aren't seen with either class, as we learned at this meeting. The new combinations, in fact, are associated with very real toxicities that can have real problems for our patients. And that, for a practicing clinician, is going to require something quite different. A reasonable question going forward is, are we at some point in immuno-oncology going to have immuno-oncology specialists who specialize not so much in the disease as they do in the immuno-oncology itself and the management of those toxicities in a way similar, say, to what bone marrow transplant doctors do. I think we're already beginning to see that, for instance, with CAR T therapy, which is much more like bone marrow transplant in terms of its toxicities than it is like anything else that we do as medical oncologists.
So you just brought up an interesting point. I'm talking about educating, faculty, but you have, nurses and physician assistants and nurse practitioners, a lot of people on the front lines managing calls and emails and so forth. And I would hope that all of our institutes would be including them in this education, because they're a tremendous resource to us and also to our patients. And I think we need to think about that. Bob, let me switch directions just for a second, because we went through the meeting and we had some great talks on biomarkers. And here we are, the meeting's over, and we still don't have a biomarker for either immune therapy or for anti-angiogenic therapy, and maybe you have a different view of that, but what are your thoughts on biomarkers for either of those areas?
You know, this has been, as you know, a rather frustrating area of investigation. I'm mainly, you know, speaking from the perspective of anti-angiogenic drugs. And I think that there was a great presentation, I think, on this topic by Herb Hurwitz, who made a number of very important points about some of the reasons why, you know, it's difficult or has been difficult historically to find and validate a biomarker for anti-angiogenic drugs, anti-angiogenic therapy. One of the points that he made, I think, is very important, is this concept of a binary biomarker. In other words, something, let's say, a mutation in a gene that predicts probable response to a drug such as a BRAF inhibitor. It's there, you can define it, the mutation is there or not. But with anti-angiogenic drugs, you don't have that. At least we don't think so. So there's this continuum. And it just makes it much harder to find, you know, a biomarker in that sort of a circumstance. However, you know, he did highlight a number of possibilities. For example, interleukin-6 in a couple of trials. I don't remember exactly what those trials were, but this has to be validated, of course, prospectively.
Yeah, one was John Hamak's
yes,
trial,
John
and
Hamak,
there was a
yeah.
pazopanib.
Yeah, but it was interesting that 2 trials showed a very similar result.
Yeah.
So I think that's something that's you know, potentially promising. I think another issue, and I know that in the colorectal cancer world, this is something that Axel Grothe in particular has commented on. I know that he's professed, at least in colon cancer, it may be extremely difficult, if not almost impossible, to find and validate a predictive biomarker for response and benefit to an anti-angiogenic drug. And the reason being that it may be that the situation is of a lot of patients responding and benefiting in a small way to the drug, rather than, say, a small cohort of patients responding and benefiting in a very, very significant way. So if it's a situation where many, many patients are, again, benefiting, then it's, I think it's going to be extremely difficult to, you know, to come up with a very promising biomarker in that circumstance.
Immuno-oncology may be different.
Yeah.
Immuno-oncology, certainly we have evidence that patients who have tumors that are PD-L1 positive are more likely to benefit from an immuno-oncologic agent, a checkpoint inhibitor, than a patient who's PD-L1 negative. And this appears to be true for both anti-PD-1 and anti-PD-L1 antibodies. The problem there, several problems there. First is that we're still in a very Wild West period in terms of validation of those biomarkers. Different companies' drugs have different anti-PD-L1 antibodies attached to them, different cutoffs for what's considered positive or negative. That we need to do a lot of validation work there as well. The more difficult problem, of course, is that there are some patients who are clearly PD-L1 negative, however so described, who still respond to immuno-oncologic approaches. So we're still not quite there yet. If one believes, and I do, that mutations per megabase, how much genomic instability you have, is associated with the number of neoantigens you have on the cell, then it's certainly reasonable also to believe that we may be able to come up with immuno-oncology signatures based upon some collection of neoantigens. And of course, not all neoantigens are likely to be equally immunogenic, and therefore not all neoantigens are likely to be particularly valuable in terms of coming up with a biomarker package. But certainly there have been some initial attempts, some published, some in development, that suggest that we should be able to come up with a package of neoantigens that will give us an immune signature for therapy.
You know, when I look at immune therapy, and we've all seen this on the survival curves, there's a tail to the curve.
Yes.
There are people who are out 5 years who 10 years ago we would say, you know, there really wouldn't be a tail to the curve. So if you have a signature continuum, Bob, like you talk about for biomarkers, and that patient maybe has a 10% chance of responding to a therapy as opposed to a 60% chance of responding to a therapy. If you're that patient, you may still want to go receive that therapy or go on a trial for that. So I think that makes it very hard for patients to make decisions and physicians to make decisions without having a binary endpoint, as Axel talked about. I think it's a lot different being in the clinic and saying you have a 10% chance. Well, 10% chance, but there's a 10% chance I could be around in 5 years, whereas with standard chemotherapy, there's a 0% chance I would be around in 5 years. So I think that's going to possibly play in. I just want to reference Bob Anders' talk on the immunohistochemistry and the cutoff for PD-L1 staining, which was about 5%, which to me was pretty low, but it seemed to be somewhat predictive. And the thing that it also came out in his talk is that he was looking at primary tumors and not necessarily metastasis, or metastasis that actually had been treated, where they may have changes in expression of PD-L1 or selection or whatever it may be. And he, honestly said, we don't have that answer yet.
And do you measure PD-L1 in the tumor or in the stromal cells? Both have been done in clinical trials.
So Bob, let me go back to your immunology background because
That's a long time ago.
it was interesting to see the presentation on vaccines, and then adding on top of it an immune therapy. And I remember Liz Jaffe giving, one of our co-chairs, giving a lecture at last year's ASCO GI, which was really wonderful, that if you don't have T cells in a tumor, a T cell can't kill a tumor. So the idea of a vaccine to get the T cells revved up and they go to the tumor and then use a checkpoint inhibitor. So what are your thoughts on vaccines, having looked at the last 30-some years of immune therapy with vaccines that have completely failed as single modalities?
Well, I think maybe you've hit the nail on the head, because it's true that the vaccine approach hasn't worked very well, but I think what was emphasized today at the meeting is vaccine plus another approach. In other words, an anti-PD-1 or an anti-PD-1 antibody, either at the same time, or I think what was emphasized today is vaccination, a vaccine first, and then followed by something like almost like a maintenance treatment with the immune checkpoint control antibody. So I think that to my mind really has a chance of changing the historical failure of the vaccine approach and make it into a success. Too early to say, of course, but at least there's a compelling rationale. I think there's some promising initial data. And that's something that I'm going to be looking forward to hearing about in the next year or so. And I would extend that beyond the sort of classic like GVAC vaccine that was discussed today, because again, there are other approaches such as the oncolytic virus approach. Could that also now fit into this paradigm of not just using an oncolytic virus as a treatment similar to, say, a vaccine, but rather combination again?
So George, let me ask you a question on sequencing, because in order for the antigen presenting cells to be active and start the immune response, you actually have to have the antigens out there.
Yes.
So should we be giving chemotherapy first and kill a bunch of tumor cells, get the antigens floating around, activating the APCs, and then come in with immune therapy? Or is it pragmatically, do you just give it together?
I think a lot of this is going to be empiric, but there are certainly tumors where we can reduce the volume of the cancer by 1 or 2 logs with chemotherapy. Presumably, if you reduce a cancer by 2 logs with chemotherapy in a fairly short period of time, you're going to be releasing a large neoantigen load into the circulation. So coming in at the tail end with an immune checkpoint inhibitor certainly might be a rational approach there. But I don't think we know yet. I think we're certainly going to need to learn. What is clear is that we're still in very, very early days. When we talk about checkpoint inhibitors, basically so far we've been talking about 3 molecules, CTLA-4, PD-1, and PD-L1. But The T cell has lots of on and off switches, and indeed other cells, as we heard with Holbrook Court's CD137 and NK cells. There are other parts of the immune system that we've barely looked at yet. I found the CD137 presentation particularly interesting because this was a presentation that basically said that if you used as an on-off switch CD137 on NK cells to activate the NK cells and then combine it with a monoclonal antibody, and Holbrook's data includes EGFR monoclonals, HER2 monoclonals, CD20 monoclonals. Those sorts of combinations appear to have a profound effect in terms of being able to suppress tumors and shrink tumors. So it's clear that we're at very early days, and it's clear that we have a lot of ground left to cover in terms of immuno-oncology.
So let me just ask one last question. When we come back to this meeting next year, what's going to be the new FDA indication? What's going to be the hot story? I'll start. I'll say I think it's going to be in lung. Hypermutated, very strong collaborative field, whether it's through the cooperative groups or whether it's an industry-sponsored trial. I think we're going to see some really interesting results in lung. So Bob, I took the easy one. What do you think?
I was about to say lung.
Okay. George?
Well, lung and melanoma are already there. I
yeah.
think we'd say. The interesting one that has come out of a recent publication is bladder cancer. The recent Nature publication on bladder cancer suggests that this is a tumor that we know to be highly mutagenized. It's typically due to a lifetime of carcinogenic assault on the urothelium. One would predict that this would be the sort of tumor that would work well with an immuno-oncology drug with a checkpoint inhibitor. The early data suggests that that is indeed the case. This is a disease for which, in essence, we've had no new drugs for 30 years. I think we'll see rapid progress in bladder cancer in a way that we haven't seen in over a generation. I think that'll be very exciting.
And I think there's a anti-angiogenic trial that's maturing right now, and ASCO GU is only a week away, so we may hear about that very soon.
Yes.
Well, I thank you both. It's been an interesting conversation. I've learned even more by talking to you this afternoon, and we hope this has been an educational event for you and everybody else who was attending this past week.
A pleasure and a great meeting.